Welcome, everyone. We're so glad you're here for today's live Q&A with Dr. Simone Elder, where she will be speaking about egg and embryo freezing. Whether you're exploring your options, considering fertility preservation for the future, or simply want to better understand the process, this is a great opportunity to get all your questions answered. You can submit questions in the Q&A box on the comments or in the comment section at any time, and Dr. Elder will answer as many as possible. And with that, I will pass it over to you, Dr. Elder. Thank you so much for being here tonight.
Thank you, Emily, for that lovely introduction. And hello, everyone. Again, my name is Dr. Simone Elder. I am so very excited today to be talking to you all about fertility preservation, in particular, egg versus embryo freezing, and why some patients might choose one over the other. So let's first start off with talking about egg freezing. Some individuals with ovaries might consider egg freezing for several reasons: delaying parenthood for personal or career goals, lack of the right time or the right partner, medical reasons like for cancer treatment or endometriosis, and lastly, a desire for reproductive autonomy and flexibility. So, a quick biology lesson. In the ovaries, every month there are a cohort or a group of follicles, and there is usually one dominant follicle that grows and ovulates an egg every month. The cool thing about egg freezing is, you take injections to grow all of those follicles with the hope that most of them have an egg, with the goal of collecting the eggs during the retrieval and then freezing them for later use. And the age that you freeze the eggs, your eggs are that age forever, which is amazing. Typically, we do see a drop in egg quantity and quality around the mid to late 30s years old. So we actually recommend egg freezing before reaching your late 30s. The younger you are when you freeze eggs, we tend to see a higher number of eggs that we freeze, a higher maturity rate of the eggs, which is actually important for fertilization later on with sperm, and a higher survival rate when we thaw your eggs. The typical timeline for egg freezing is that you have an initial consult to get your medical histories and to review the egg freezing process. Then, whenever you are ready, you might start a short course of birth control at the start of your period. And the reason we might give you birth control is to help synchronize the follicles prior to injections so that they can grow together. You will then stop the birth control, get a bleed, and then come in for a baseline scan. Typically, the total number of days of ultrasounds and injections are about 11 to 14 days, with about 8 to 11 days of injections. You then take a trigger shot, which causes the maturation of eggs in the follicles, and then we do the egg retrieval 36 hours later. The egg retrieval itself is about 20 to 30 minutes with IV sedation, and then we go through the vagina with a transvaginal ultrasound probe with a needle on top. We then aspirate every follicle to retrieve as many eggs as safely as possible. Now, embryo freezing, which is also known as embryo banking, is a little bit more involved because you do need a sperm source to make the embryos. You still need to do all the injections and an egg retrieval, but you are taking fresh eggs and combining them with sperm. And once they are fertilized, we basically watch them for about a week to see if they grow into embryos. Now, I have patients who come in already knowing that they're going to freeze eggs, and other patients who already know they're going to, do embryo banking. But I do have some patients who are considering one versus the other. And so there are a couple of things that I definitely talk to them about. One of them is the final embryo number. So the survival rate after thawing eggs is about 80 to 90%. So for example, if you have 10 mature eggs that are frozen, maybe 1 to 2 won't survive the thaw. Versus thawing embryos is a little bit better in terms of final numbers because all the mature eggs that are retrieved are fresh and are combined with sperm, and then the embryo itself is frozen. And the chances that an embryo not survive the thaw overall in the United States is typically less than 5%. Secondly, is cost. So for those who are self-pay, egg freezing is typically cheaper at the time of freeze. But again, if you use them later on, the cost might be equivalent to making embryos outright. However, if your insurance has fertility coverage, you might be able to have embryo banking covered, but not egg freezing, unless you are, a cancer patient in an insurance fertility mandated state, or your job covers egg freezing. Cost is obviously important, so I think it's critical for patients to acquire with their company's insurance benefits and clinic financial coordinators to try to figure out what works best for them. And lastly, I save this one for last because I think it's the most important, autonomy. Your eggs are your own tissue versus embryos. There's more stipulations in terms of divorce or death of a spouse, and you have to decide what to do with the embryos in those situations prior to even starting injections. But all right, I think that's it, Emily. I will take any questions.
Great, thank you so much. So we had a few questions submitted beforehand. So what age is considered the best time to start thinking about this process, whether it's egg freezing or embryo freezing?
Yeah, it's a good question. So, typically I would say like your late 20s to like mid 30s would typically be the best age. You don't want to wait into your, in your late 30s or, early 40s because you start to worry about egg quality then. You also, outside of like cancer treatments or anything like that or oncofertility patients, if you're just purely elective egg freezing, if you do it too young, the risk of doing ovarian stimulation and egg freezing might outweigh the benefits. So like surgical risk, for example, and risk of ovarian hyperstimulation syndrome. So that's why, and then you might not even use the eggs if you, freeze too early. So definitely like the late 20s to like mid 30s for sure.
Right. So that brings me into our next question. How long should someone try naturally before seeking help from a specialist like you?
Yeah. No, that's a good question. Typically the, definition of infertility it's mostly based on age. So, for, individuals or couples less than, the age of 35, or at least couples trying to conceive, usually, a year is when they should, after trying to conceive for at least a year, they should go see a fertility specialist. They consider like an infertility. And then couples who are over the age of 35, 6 months is when we typically would recommend getting evaluation by infertility specialists. Well, honestly, I think I see couples who try like 3 months and they want to be evaluated just to make sure that things are okay from a male or female standpoint. I think that's totally valid. And, I definitely welcome that.
Right. Um, how many eggs are typically recommended to have a strong chance of a future pregnancy?
Yeah, that's a good question. So, I always have to calculate with my patients, like having the calculator there after going, like getting their ovarian reserve testing to kind of predict how many eggs to get. But I would say like overall, on average, we like to see per live birth, 15 to 20 mature eggs. And the reason why that number is because you each step of the process you have attrition. So you lose, like you start from a higher number and then go down in number. So for example, like say someone freezes their eggs at 35 years old, and they froze at 35, they froze 15 mature eggs. Or sorry, they freeze like, I don't know, 16 mature eggs, okay? And then 15 of those eggs, mature eggs survive the thaw. Okay. Typically we might see like a 70, like when we fertilize it with sperm, we might see like a 75%, 75 to 80% fertilize. And then we typically see the biggest drop off when the embryos are developing. So maybe 50% of embryos develop from like the early fertilization. So maybe like from the 12, 6 become embryos. And then from there, for 35-year-olds, maybe like 1 in 3 of those embryos when we do genetic testing are actually chromosomally normal embryos, so like or euploid embryos. Um, and overall, we typically say that most couples are typically able to have a live birth within like 3 embryo transfers. So that's why like you start off with like 15 to 20 mature eggs. It's a lot of math, so it's fun to talk it through.
Yeah. Yeah. And I'm sure everybody is different, so you give,
Exactly.
you know, a different age, different people. It's
Exactly. Yeah.
um So somebody just commented they have their three babies are from RMA, and they said thank you, RMA. So congratulations. Um, uh, how many embryos do you would you recommend people bank? Is there a magic number for a live birth in the future?
Yeah, so typically I like counsel my patients like having three euploid or chromosomally embryos per live birth. RMA actually did a study kind of looking at that question. It was a little bit more involved, but they said like typically with our cohort, maybe like 93% of patients typically have a live birth with three euploid embryos. It's a little bit more nuanced with it, but so that's typically like three is the number that I used for patients per live birth. So, obviously it depends on your family size goals. You might not even go through all three of the embryos per live birth. We have pretty good rates, about 60 to 70%. So that's why the three, just in case like the first one doesn't take or something like that.
Um, Here's a question that just came in. What's the biggest misconception that you've heard with egg freezing, um, that you can think of?
Oh, that was a good question.
Yeah.
Let's see here. Let's see, the biggest misconception.
Is it that, it takes all of your eggs, like that you don't have any future eggs or,
Yeah, I think that
something
probably
like
would
that?
be, yeah, exactly. Like people think, interestingly, so I think when in the beginning I talked about, there's a cohort of eggs that come up every month. The cool that, like in general, nat with a natural menses or period, you have these resting follicles that come up, and they're all vying to be like the dominant follicle that ovulates. So typically one to two, it's usually one survives and ovulates, and everyone, all the other eggs that came up in that month die off. But the cool thing about IVF is that we're going to recruit those eggs anyway. So instead of them dying off, we're recruiting them to grow and hopefully have an egg for the egg retrieval itself. So
Great.
I guess long
Thank
story
you.
short, you would lose those like eggs in that month anyway, if that makes sense.
Yeah, it does.
Yeah.
Is the procedure uncomfortable? And what is the recovery like afterwards?
Yeah, that's a good question. I would say honestly, the what I've heard from patients, the most uncomfortable part would be when you're close to like the trigger shot that you take, and then you go to the egg retrieval 36 hours later, your ovaries can be big. So you can feel your ovaries. So, when you're lying down, when you're living your regular life, you will notice your ovaries when you probably never have noticed them before. But then the egg retrieval itself, it takes about 30 minutes. There's you, excuse me, have IV sedation. So you're asleep for the whole procedure. And you don't feel the procedure itself. And it usually lasts 20-30 minutes. I would say some patients, most of the side effects from the egg retrieval are going to be like anesthesia. So you might feel a little bit out of it for the rest of the day. But most of your pain is well controlled over the counter medication. So Advil, Tylenol. Some patients might need, stronger medication to kind of help with the cramping. But pretty much you're back to normal with the next day, which is pretty cool.
Great. That leads us into our next question. And you may have mentioned this earlier, but a timeline from like the initial consultation, someone comes to see you to, the day of retrieval for the eggs. What does that look like?
So you'll see your doctor or PA for the initial consult. And they're mostly getting your medical histories, making sure there's nothing um that usually there's not much that would prevent a patient from undergoing an egg retrieval, but making sure there's nothing that really jumps out in your history. Um, and you then will usually regroup with the doctor. So the testing that you normally will get is we're looking at your ovarian reserve testing. So what that means is your anti-Müllerian hormone or AMH and your resting follicle count. And that kind of lets us know like how many eggs we're expected to hopefully get, and also how much medication to give you. So usually sometimes my patients like to regroup and talk, we go through what medications I'm going to give them, how many eggs were expected. We do some calculations that I mentioned before. And then we kind of talk about, the whole procedure itself and the stimulation medications. And then pretty much whenever they're ready, they can start the egg retrieval. So usually they will let us know when they're the first day of, their period. And then we put them on a short course of birth control around like a 2-week course to help synchronize the follicle so that they will grow together when we give them injections. Um, so then, yeah, short course of birth control. And then you stop the birth control, and then you'll get a bleed after that. And then you come in for an ultrasound. And basically, I look at my patient's ultrasounds and I'm like, they're good to go to start the injections. We typically start injections on like the third day of that withdrawal bleed from birth control. And, it's typically 2 injections that they take. And then they help stimulate the ovaries. And then they take another medication to help prevent, you're growing all these follicles. They're going to want to try to ovulate. So then we add a third medication to prevent that from happening. And then, you're coming in for ultrasounds initially, like on the third day of injections, and then maybe like every other day for a couple of scans. And then once you're getting close to taking the trigger shot, you'll know because you're going to be coming into ultrasounds like every day for a few scans. And then, your doctor says, all right, she's ready for her egg retrieval. And then they'll take the trigger shot, and then 36 hours at trigger shots at night, usually, very early in the morning. And then come in for your egg retrieval 36 hours later. Um, and that's pretty much it.
All right, thank you.
Yeah.
Um, it's the day of your transfer. You have 6 frozen embryos. How do you know which one, they're going to choose? Is there a process there?
Yeah, yeah, for sure. So we usually talk about this before we even get to the actual transfer day. Um, But, there's a couple things we look at. The first thing is, embryos get a grade from the embryologist, looking at is kind of like the inner cell mass, which becomes the baby itself, and then the cells that become the placenta. So there's like 2 little grades that is most important for us that we look at. And then um, so we look at that, and then we also want to know for if you do genetic testing, you obviously want to do a chromosomally normal embryo. And then some patients, have a sex preference as well. So we take that into consideration if they rather have like XX or XY, female or male embryo sex preference. So taking those both into consideration, then that's how we're able to pick the embryo. And then, some patients, just pick the best quality, and that's when we typically look at the grades of the embryos that I mentioned earlier.
Great. Um, so someone's prepping for their egg embryo freezing, and their retrieval. Um, their iron levels or ferritin levels, is there anything you can tell us to support that or to like have like a healthy stimulation cycle?
Yeah, one of the, risks to an egg retrieval is bleeding. That's probably the most common risk. So we definitely want to make sure that your iron sufficient before, or that your hemoglobin or hematocrit are sufficient prior to doing an egg retrieval. If you are deficient, then we'll do an evaluation to kind of optimize you prior to an egg retrieval. But yeah, and if you're not, then you can go forward with the egg retrieval.
Great.
We look at all of these things. They're all really important questions, honestly,
Mhm.
because we want to make sure that your health is optimized prior to going to an egg retrieval. Because it's not a completely benign procedure. So yeah, these are really important questions.
Yep. Great. So you mentioned the sex of the embryo earlier. If you don't want to know the gender of the embryo, can it be hidden, or is that information that's always given?
Yeah, so it can be hidden. And then say later on you want to unmask it, you can let the testing platform know, and they can reveal that for you as well. So some patients, it's really cute. They don't know. And then, sometimes we've put the sex of the embryo in like an envelope and they open it up later or whenever they want. But yeah, but we definitely, obviously we do, a lot of patients do genetic testing of the embryo. It's, 98% true. Like the results are actually, correlate with the actual sex of the baby, but there is that 2% chance that it might not be accurate. So, we recommend for sure, like testing of the baby itself later on in pregnancy for sure.
Great.
What to do with like cell-free DNA, non-invasive testing, stuff like that.
Yeah. Um, how long can eggs be preserved? How long can they be frozen for? Does the quality decline over time?
Yeah, it's a really good question. So the cool thing about egg freezing is that they can be stored their age forever. So, you can freeze eggs at 28, and they will always stay 28 years old in terms of quality. And you can use them when, you're 40 years old. So, I think that's pretty cool.
Yeah.
And the quality does not decrease. It's, frozen. So, yeah.
Right. Here's an interesting one. Can you work out during the egg freezing process?
Oh my gosh, this is such a good question, especially I'm in Colorado. So, we have so many active patients. Yeah. So, yeah. It's interesting. Like, we typically don't recommend intensive exercise when you start the injections. And the reason for that is because your ovaries are getting bigger, and you have actually a lot of space in your pelvis, in your abdomen. And so the bigger, your ovaries can actually twist on their blood supply and lead to ovarian torsion. Um, but that doesn't mean you have to be like bedbound or anything like that. I actually don't recommend that. You could do light walking. You can do like very calm cycling, not like jumping up and down or anything like that. Definitely don't recommend like intense like marathon training during the egg retrieval. So yeah, I just tell my patients to stick to walking and some gentle exercise. Rowing can also be good too. I feel like weightlifting, that's like not so heavy though, because you worry about straining too if you do heavy weightlifting. But just calm weightlifting.
Great.
Yeah.
Thank you. And here's another interesting one too. Traveling, uh, with the injections and everything, what do you
Oh, yeah.
recommend?
Yeah, so I feel like the only time you can like safely travel is when you're on like the birth control time period. So again, you're gonna get your period and then we might put you on a short course of birth control. You're just on birth control. We're not doing any blood work, imaging, anything like that. But once you stop birth control, I would definitely make sure you're in town because you're going to get your period and you have to come in for a baseline scan. And then a couple days later, you're going to come in for another scan to see how your ovaries are responding to the injections. And I can't predict, when I'm going to bring a patient back at that point. Maybe it'll be like the 2 days after that one, but sometimes I have to bring them in the next day, to see when I want to start that other third medication to prevent ovulation. So, long story short, when you're actively taking injections, make sure you're in town. But if you're in birth control, you can live it up a little bit before, having to be in town for the injections.
Great. Here's another question. I'm 35. Is it still worth it for me to freeze my eggs?
Oh yeah, for sure. I feel like that 35 is definitely like the perfect age. Obviously like when they compare, egg quality compared to like a you know, 26-year-old might be a slight, decrease, but still, if you were to create embryos of the 35-year-old eggs, it's still significantly better than waiting, 38 or 40 years old. So 35 is definitely a good time to do it.
Great. And I think you talked about this, the egg freezing success compared to embryo freezing.
Yeah, yeah. Typically, so the thing is the thaw, surviving the thaw. So, with egg thaw, maybe 80 to 90% of eggs survive the thaw. So if you have 10 mature eggs, then one or two might not survive the thaw. Um, versus like embryos, overall, it's lab dependent, right? But overall in the United States, I would say like less than 5% of embryos survive the thaw. Do not survive the thaw, sorry. Do not survive the thaw.
And let's say, you freeze your eggs when you're 23, 25. You're living in the city. What happens if you move?
Yeah.
Can you move your eggs?
Yeah.
Does it hurt them?
Yeah, so that's a good question. Yes, you can definitely transport your eggs. You have to do a lot of coordination, obviously, with the different clinics that you're talking to. Usually I do have some patients that actually come back to us, to like, make the embryos and stuff like that. But yeah, if they're across the country, you can definitely ship them there. Obviously there's like the whole caveat of like, you know, we don't know what's going to happen, snowstorm, whatever. Like, but most of the time, like the eggs are, oh, almost all the time, the eggs make it there safely, enough for you to do the thaw and make the embryos where you live at.
Great, thank you. I think we have time for one more question. This has been fantastic, so thank you so much. Um, how does AMH affect your ability to freeze eggs, and does it affect it?
No, this is such a good question. And something I like talking about in general is like ovarian reserve. And, AMH is one of those markers that we look at for ovarian reserve. So, for egg freezing and AMH, we typically look at that value to figure out how much medication to give you and kind of along with your antral follicle count, the resting follicles, how much medication and how many eggs we're expected to get. Now, in terms of egg freezing, if your AMH is less than 1, we're like, okay, we might have to give them a little bit more medication, than someone with an AMH of like 2, for example. Um, but that's just for like AMH in general. There are other things we look at, like age, for example. So you can be 27 years old and have an AMH of 1.3, versus like someone who's 40 with an AMH of 3. The quality of the eggs is more dependent on the age. So, obviously we might have to give you a little bit more medication, but we think like, okay, this person's freezing their eggs at 27. They're more likely to have better egg quality, have maturity rate as well. And then also more likely to survive the thaw. Like age is an important factor with that. I hope that made sense.
It did, yeah. Thank you so much. That was great. Um, let's do one more question.
Okay.
Um, does long term, does it affect your hormones doing an egg freezing cycle?
Yeah, so, the good thing about the injections, and the egg retrieval itself, it's a limited amount of time that it will affect your hormones. So it's purely like the amount of hormones that you get is due to the eggs that we're growing. So once we retrieve the eggs, that's it. And then obviously your first cycle, menstrual cycle after the egg retrieval might be a little off just because we just did a surgical procedure on your ovaries, but patients are able to have normal cycles, the subsequent menstrual cycle period, and it doesn't have long-term effect on your hormones.
Great. I think that's a good place to end. Really appreciate you being here. This was fantastic. And thank you everyone for your great questions. We'll be doing more of these coming up. So follow us on Instagram and you'll see maybe we'll have Dr. Elder back. I think she had fun. So thank you so much, everyone. And it was so fun tonight.